This week on the Backtable podcast.
We always try to think that we need to come up with these scientific parameters, right? But the real impact to patients is what they're seeing every day and studying every day and able to market every day, not the percentage of shrinkage or what particles you're using and none of those foolishness, right? They're showing us that if we meet women where they are, if we provide access, and if we're creative enough, that we can make an impact anywhere we want to.
Welcome to the Backtable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com. Now, a quick word from our sponsor.
Greetings to our esteemed IR community. Picture a future where cutting-edge interventional technologies are seamlessly integrated with world-class imaging tools designed to reshape procedural efficiency, enhance precision, and foster patient-centered care. That's our vision at Varian, and we're working with partners across Siemens Healthineers to bring our vision to life. What sets our Embozine and Oncozine microspheres apart? Features that are designed to enhance procedural and cost efficiency, like precise calibration and syringes that contain more microspheres per volume, which means fewer syringes per procedure. Embozine microspheres offer a broad spectrum of 10 sizes, each with distinctive colors, facilitating visualization of suspension. This streamlines the treatment process and reduces the potential for errors. Visit us at varian.com/interventional to learn more. Varian, a Siemens Healthineers company, we pioneer breakthroughs in healthcare for everyone, everywhere, sustainably.
Now, back to the show. I'm your host, Dr. Ali Behetti. I'm coming to you from Tacoma, Washington. I have the pleasure today to bring on two very special guests. One is Dr. Janice Newsome. She is a professor at Emory University. And my second guest is Dr. Azza Naif, or I have been told to call her Sweet Azza, and she is a IR attending at MUHAS and a member of the first generation of Tanzanian IR trainees. Dr. Newsome and Azza, welcome to the show.
Thank you so much. Great to be here.
Our topic today is really going to center around uterine fibroid embolization, and we're going to focus on talking about UFE, global accessibility and affordability. So for those in the audience who don't know you guys very well, do you mind giving me a little intro about how you two connected and how this became such an important topic for you?
Your turn, Azza.
I'll let Dr. Newsome speak.
I'm often asked about several different things around how I'm connected to the road to IR. And I love the way you asked this question, Ali, because truly, it's not about the organization, but it is really around how Azza and I connected or how the people actually connect. So I would say that it probably is a little bit of a mystery, but Azza is my kindred spirit. So years and years ago, there's been Backtable podcasts about the road to IR. So I encourage everybody to go and listen to that. But I'm going to tell you my special connection to Azza, besides the fact that we both love sweets. We are women that like treating other women and have a passion for making sure that other women get to fulfill their goals and live their best lives, is that Azza and I have this other thing in common, and that is family. So really, Azza is my sister because unbeknownst to many, is that I have been adopted by Azza's parents as one of their children. So yes, we have this very formal connection through Road to IR, and I'm proud to say that Azza was one of my mentees, and now she is one of my mentors, that she is my partner and friend and colleague. But the best description of who Azza is to me is that she is my sister by adoption of her parents.
Well said. I don't think I can add more.
That's quite an accolade, really. I mean, Azza, when did you first meet Dr. Newsome?
Oh, we met, was it back in 2019? Yes, that's when we first met. Unofficially, of course. But truly, I think it was 2018, really, right? And then we started meeting up 2019.
You got it.
Yeah. And then from there onwards, we've just been in touch. And it's been truly amazing.
Amazing. Yeah. So you've kind of developed this collaborative relationship over the past 5 or 6 years, ending up in the fact that you pretty much practice independently there now after treating the first generation of Tanzanian IRs. It's been a while since we did our last Road to IR episode. Any chance maybe, Azza, you could provide us a little update with what the clinical practice is like there now?
Yeah. So the clinical practice really has been, I would say we've been somewhat established right now compared to how we were before. So currently we see patients every day. We just do walk-ins. We don't really do appointments until now. It's just because it's something new. IR is still something very new in our setting. And we still want to capture like all patients really. So we don't have appointment per se, but we have walk-ins. So we do clinics every day from Monday to Friday. Clinic starts at 9 a.m. to like 3 p.m. That's when we stop. And sometimes we see as many as 30 patients in a clinic, sometimes 20 patients.
Wow.
Yeah, the lowest number we would have would be like 15 patients in a day. And that does not include patients from the ward and also the physicians. Like they come in and consult every day, every single day. So yeah, it's been going on and it's been getting busy by the day.
Hey, that's awesome to hear. I think we were just talking about before we got started here that you have a special guest in town this week, and patients are texting you day and night to see if they can get in and see this, this professor. So you make yourself really available to your population and to your patients. I'm sure that's really appreciated.
Yes, we're hoping to do as much as we can for the patients here for whatever, as little as we have.
What's like a typical day of cases for you?
So usually what we have, because we have 2 working rooms at the same time, we have one that we call an ultrasound room, which before we had a regular CM there. So we had an ultrasound and a CM in the room. And then the other room now is the angio room. So we do all the biliary cases, PCN, all the vascular cases are done in the angio room. And only the ultrasound guided cases, we have them in the other room. And then time on and off, we have also CT cases. So for CT, we do them in the CT room where it's also for diagnostic use. So we have like 2 patients maybe in a day, and then we have like 2-3 patients in the ultrasound room, and then we would have like maybe 4 patients in the angio room. So total sometimes we have like 6 to 8 patients per day.
Busy day, yeah. Tell me a little bit about your staff and your residents. How many attendings do you usually have on, and then how many trainees do you have?
So currently, we have 3 attendings that work primarily in the Muhimbili National Hospital. That's where I work too. And then 1 attending is from MUHAS, that's Muhimbili University, which are separate institutions. So we are 4 of us, and then we have 6 fellows. So 3 fellows from junior class and 3 fellows from senior class, because our fellowship is 2 years. So we've divided them into 2 classes. And then daily we have 1 attending in clinic, and this is accompanied by 2 fellows, 1 junior, 1 senior in clinic, running the clinic. And then we have 1 attending running 1 room, like the angio room, and then the other room, the ultrasound room, and a CT room. So we have all rooms covered at any day.
Wow. Sounds like a really amazing training opportunity and experience for your trainees. I'm like a little jealous, not gonna lie.
You should come visit us.
Me too, Ali. Me, Ali, I'm totally jealous.
Right?
I'm totally jealous.
You should come visit us.
For sure. Let me talk a little bit about the topic that we came to talk about. How did you first get involved with UFE procedures, and how did you figure out that there was such a big opportunity in the population where you live?
Okay, so from the beginning, I would say when we started really, we started only in the non-vascular procedures. So those included like biopsies. We just wanted to capture patients. And by then it was not official, like in the hospital. So we started in 2018, but the fellowship really began in 2019. That's when we started. So when we started in 2018, we just wanted to start small. So we started with biopsies, aspirations, and all that. And then as we progressed, depending on whoever was coming in, would introduce 1 procedure at a time. So then we started, somebody say, okay, there's this procedure called uterine fibroid embolization. Have you guys heard of it? And we're like, oh yeah, we've heard of it. So before we started Road to IR, we had one person that would come at a private clinic somewhere here in Dar es Salaam that would perform these procedures. But he would just be like coming in for 2 days, treating like 20 patients and then leave. So we went and observed specifically uterine fibroid embolization. That's what he came for. Yeah, so by then we never had any physicians for IR physicians. So when we went, it was really interesting to see how they would treat, and then the patient would go home on the almost the same day or next day, really. And then the patients would do well, because whenever he came in like once a year or maybe twice a year. So he would make follow-up of those patients he did before. And then he would say, oh, look at this compared to this and compared to this. We're like, this is really interesting. And then also women have other options too. So that's when we started now this training, like in 2018, we said there's this procedure we used to see. I think we should incorporate it. But in the beginning, it wasn't really easy. I mean, until now, it's not easy, because you know how it is. Other physicians get threatened when they hear minimally invasive. Patients can go home on the same day or next day. So we did a presentation, I remember, at OBG department, and all the doctors were there. They started asking questions. Also, how sure are you that these procedures would work? How sure are you that, the symptoms would go away? And what are the complications of the procedure? So a lot of them were interested in knowing, what kind of fibroids would you treat with these procedures? Which the answer is really any, right? So yeah, we're still in that mode. So until now, it's interesting. Some of them actually refer patients to us, but some of them are like, no. And then the way we get patients really is through other patients that we treated.
It's so true, right? For UFE patients? Oh, 100%. I mean, I think that's cross-cultural. I mean, Dr. Newsome, maybe you could speak about it too with your extensive experience, but there's no better advertisement than like a satisfied patient for a UFE procedure.
That's true.
That is absolutely true. And, not to just to put an exclamation mark on what Dr. Azza have said, I think what we're seeing in Tanzania and in a lot of places where procedures that affect women's health, namely, we're talking about fibroid embolization here, that it is almost accelerated the introduction of these procedures in the US and in Europe, right? So it's kind of an interesting perspective to see something get started, right, in a place where we have been there before, yet because of some of the lessons that we have learned about how to start a UFE practice or how that procedure is developed in the population, some of those lessons are being duplicated because of just the nature of how medicine is practiced everywhere in the world. But some of those lessons have already been learned, and now they don't have to be experienced. So, from my perspective, no matter where I go, and I say this all the time, I don't know enough Swahili to have a big conversation with any woman. I can say a few words, and even then it gets me in trouble, right? Azza pole. However, the one thing that is very universal wherever I go is no one has a medical degree. They don't understand all of what is going on, but you can hardly speak to a woman that is having abnormal uterine bleeding or infertility or these bulk symptoms. They may not know what it is that's causing it, but it's funny how the word fibroids is almost universal anywhere you go. You can, they don't know any other words, no other English words, but somehow they understand this word fibroids. And I think that, it just speaks to this prevalence of the disease and how we keep talking about it, and that it is something that, universally women everywhere are experiencing, and that, yes, there's something that can be done about it. And whenever we find that there are things that we can do, Ali, here, whenever you find that there's something that you can do that improves anybody's health or save anybody's life, my motto is always, and, Sweet Azza and I will say this, is that you wouldn't just want to do it where you are. You wouldn't just want to do it. So already, although this is an infant stage of introducing UFE in Tanzania, and not so infant now because we have people there that can do it and are doing it. And we've trained people that are going out and can do it. We know that it's being done in other places in sub-Saharan Africa. It's still that you want to do it more. You want to make sure that more people are aware of it. And so it brings us right to the middle of this conversation, which is this access issue, access to care, access to Azza and people like Azza, both in the US and in other places in the world. So having a clinic every day, if I could have clinic every day, I don't even know. Well, obviously our big institutions will have somebody that has clinic every day, but the ability for patients to be so accessible, Ali, this is something that we can learn here in what we are referring to as the global north now, right? Because now we don't have that same accessibility to us. Because if you can't get to us that are providing the care, then you're not going to be able to get the care. So it's first, how do you find an Azza? How do you find a Morvana? How do you find a, Funzi or IR Doc Nigeria or Dorothy? And these are all names of women and people that have trained under, our Road to IR system, or where SIR has made a deposit, that they've said that they want to bring this good news everywhere and be able to treat women that speak in the name of fibroids without understanding that there are options for them. I don't know if that was okay to say.
Oh, definitely. Yeah. You touched on one of your barriers being referrals from GYNs, and having your other referring providers not really believe in the therapy. I'm sure you face a lot of very unique challenges and challenges to even getting the patients in. Could you touch on that a little bit?
Not only like the barriers being that the physicians don't believe in the procedure itself. It's because mainly over here, maybe elsewhere too, like most people would work. It all comes back to money issue, right? So it's like the source of income, right? So for them, when they do myomectomies, those are also sources of income to them. So, and I think that's what maybe probably they're more scared of. Like if I give you my patient and you just do this minimally invasive and then the patient goes home the next day, I don't really get anything from that. And then they do the follow-up. So we also do the follow-up of patients. So, and then the patient, myomectomy really, procedure itself, it costs something. And then the patient will stay in the ward for like, say, 5 days. Meanwhile, we only just like let the patient go the next day if the patient doesn't have any issues. So I think one of the things that scared them most is mainly just the revenue, really. Like they wouldn't really have that. And the other thing is probably, I'm saying this because I'm not really sure what their knowledge is with the procedure itself. So probably it's just they're scared because they don't really know what it does and how it's performed and what it brings out for the patients. So maybe that's about it, really.
Ali, I think it's the same here to some extent, is that IR and everywhere around the world itself, is that, although we're so great at what we do, we're not so great about explaining and spreading this gospel either to our colleagues or to the population about what it is that we do. We sometimes ourselves have a hard time with the language of explaining what we do. Do we do minimal invasive surgery? Do we do image-guided procedures? And then the worst is that we're performing all these amazing things, which, by the way, I say the worst, but it's the best of us, it's the worst of us. And then, but patients just leave with a Band-Aid, and we love that aspect of it. Like we could just go in and do all kinds of stuff, right? And then what you get is a Band-Aid. But I think the gravity of the impact of what we're doing, because there's such a small footprint on the outside, is not always well realized. So this turf battle is going to be fought from now till eternity, even in places where the turf should not exist, right? So in academic centers where everybody should be working for the good of the patient, right? The turf still exists. If it's not for financial reason, it's, our trainees need to have experiences with doing myomectomies or hysterectomies. And if it is in the VA system where the care is available and access to care should be equal, there's still that sense of it. So, we have learned, and through many, many studies here in the US, that this access to care cannot be put on the backs of the OBGYN's referral system, right? It ultimately is still going to be, what is it that we need to do as a community, as well as educating our GYN partners. There's not a lack of studies and things in the literature to say that uterine fibroid embolization as a procedure is safe and effective, it's cost effective, etc., right? But the message still doesn't break through. And so I think altogether as a community, we can't just choose one way to be able to communicate. It has to be all the ways. It's through the OBGYNs, it's through community events, it's through word of mouth, it is through social media and someone saying this, it's through advocacy and lobbying, and it's through Backtable podcast as well, right? It's through all of these things. It's through our industry partners, making it easier for the providers to actually know that this procedure exists, because a lot of our industry partners sell the same equipment that performs the surgery, right? So it's not that it is right. They're selling fallopian tube recanalization equipment. They sell the equipment that also does myomectomies and stuff, right? So it is how do we use our best knowledge to say that, UFE isn't right for everyone. It isn't, right? But how do we make sure that we're not overperforming another procedure while someone else could get this procedure? I think I prefer to imagine it in that way.
You bring up some really great points, Dr. Newsome, and I'd like to talk a little bit more about kind of some of the economics involved. Dr. Azza, perhaps you could help us understand what the biggest barriers to, getting the equipment that you need for these procedures. And then talk a little bit too about your equipment choices, like what has made sense for you.
The biggest barrier being the equipment. That's for sure. I would say that's the number one barrier for almost like many procedures that we do. But fortunately now we do have some, I don't know whether I would call them agencies or companies that actually ship some of these equipments through, like, from China or from India, apart from the American companies, of course. So we do get some equipments. But when it comes to uterine fibroid embolization, of course, we're still stuck in the same thing. Like, it's not easy to get these equipments, especially like so mostly what we use here, we use PVA particles. So it's not easy to get the PVA particles from other companies. So we have a struggle with that. And also the catheters that are mostly used. So, and the micro catheters, of course. So we've been placing orders in our groups here, like the agencies here, and we're still waiting to hear if they have those micro catheters. So talking of what makes sense to me so far, I would say, because we've been trained, the good thing, I would say that the best thing was that we've been trained with so many people. And that has given us a wide range of equipments that we can use. I would say that's a huge advantage to us. So while other people now are used to like the uterine artery catheters, like the Roberts catheter, which is absolutely amazing to use, we have been told that you can actually just have a comfy catheter, a good wire, and a micro catheter sometimes. That's all you need for the UFE. And actually, that's all you need for any procedure, really. So I remember one of the attendings, he only uses comfy catheter, no any other catheters. And it works every time for almost everything, except for when you want to do other procedures, of course. But for UFE, yes. But for UFE, I think if I had a choice, of course, uterine artery catheter is the best because you don't have to maneuver much. You can get anywhere you want in the uterine artery. I would say the next best thing for me would be a glide comfy, really. Like, because it gets you there. And then if you have a 5 French and you have a micro catheter, that really works. Like, you don't struggle much to get where you want. So that would be my choices, I would say.
Dr. Newsome, you have a choice du jour for UFEs. How do you like to do yours?
So it's like amazing, to hear that, because again, this is also the evolution of this procedure, right? It's like everybody had to form a Walkman's loop with whatever your catheter was, a Compi, a Cobra, whatever it is. And then we were able to develop longer reverse curve catheters, and figure out how to make this part of it a little bit faster. So as you see this procedure being developed elsewhere in the world that don't have access to these sexy catheters and all our things, then you're seeing the same thing that we started with. Actually, that's the way it is starting. But can we really afford to wait all those years for the implementation when what we know can work and work faster is available now? And so that is where I am now. Yeah, I'm at Emory. I can choose whatever microcatheters and wires that I want. And I have the luxury of being able to choose the opposite of what the trainee says. Don't tell them that I say that.
Just to be contrary, right?
Well, just to give them experiences, because the reason that people sometimes say, Ali, that, I'd like to start off with a blank, it's because that is their comfort, right? But how are they going to get used to the uncomfortable if that's not exposed when I'm there? But if I had no trainee, then, I do favor using the Roberts uterine catheter. I typically will also use a microcatheter for every case. And my favorite is Prograte by Terumo, and was always start off with a double angle GT glide. Those are like the things that I know that works well in my hands all the time. And yes, I don't use PVA at all for fibroid embolization. I believe in spherical particles. And yes, our trainees and at Emory, we have our run of everything that we could want, embospheres and embozines. And I know that Varian is sponsoring this event. This is not because they're sponsoring this event that I say that I am a believer in precise calibration of particles, because I believe in the science of it, though that we don't see right now the evidence to say that it creates less or that the outcomes are superior, right? But this is my secret why I love it is because our training pathway is different now. I get new trainees almost every month. It isn't that I know, Ali, if you spend July to December with me, then I know that you know all of my quirks, and then by March I could just stand outside the room and watch you, right? I'm literally doing like a new person, all the time, which is a great thing to some extent. But the ability to teach good embolization technique habits when you can see the particles. I love the fact that their color of the particles. And now I could say, you thought that you didn't have any particles on your gloves, but let me show you that you've just violated the space, right? Which is not as easily taught with embospheres. Great company in particles as well. But it helps me to train something else. And that's why I tend to use more embozines than other particles. And I think that the studies have shown that really PVA, embozines, embospheres around the world, and now with some of the other providers using things like Fair Embo, and it's what we're trying to do is to say that wherever you can get access to the uterine artery, and I can choose my sexy particles now, but Azza doesn't have the ability to do that. But what Azza has the ability to do is to say, what do you have at your disposal? And how can we make sure that you are doing this in a safe fashion, that you can block off the blood supply to the vasculature in the fibroids and not create more harm to our patients? And I think that, it's a place of privilege when we start having this whole conversation about, what is your perfect particle sizes and stuff. I want to say that, for doing fibroid embolization around the world, I hope that we can provide the equipment that is necessary in the environments that the procedures are being performed, and training the people that are using that equipment to be masters of it. and not just this is what I love as a. And by the way, love I love Dr. Cumpy, who is a friend of Road to IR already, but it doesn't serve all the things that I need to accomplish by using a Cumpy for every case. It just doesn't work for me that way.
Let's shift over a little bit to talk about pain control pre, post, and during UFE. What have you found, Dr. Azza, to be the most effective pain control regimen for your UFE patients?
Okay, so pre-procedure, of course, we only just give like antibiotics before the procedure starts. So we don't give any pain meds before. And then intra-procedure, we usually use moderate sedation first. And then we would also give intra-procedure like paracetamol and opioids, of course. And then sometimes we would also give diclofenac injection, just like during the embolization process. And we would keep giving the midazolam and fentanyl together in the procedure. And then post-procedure, what we usually give, we usually admit patients post-procedure for 24 hours just to monitor their symptoms. And what we usually give, it's a combination of paracetamol, we give diclofenac, we give opioid injection, and then we give these antiemetics and fluids, of course. So these, like the combination of paracetamol, diclofenac, and opioids have been actually amazing to us if they're given in time. And patients next day, you would see them like, oh no, I had no pain, but maybe I just had nausea and all that, which are like post embolization things. So so a few patients, of course, not all patients are the same. So a few patients would still say, oh yeah, I was given this medication, but it's still, the pain has still, it was still there. But then if you look, it's all like in the format of embolization. So we just try to tell patients prior to procedure that you might experience 1, 2, 3 post-procedure, and this can be normal. But if it's more than, so I write you extra medication, they can give it to you whenever you feel that extra pressure from the pain. And then once they go home, so the next day, we always give them, there's a medication that I like to give patients. It's called Paracodenc. So it's a combination of paracetamol and codeine, and it works very well with patients. So that, and then diclofenac again, and then we give them antiemetics and antibiotics, of course, to go home with. So most of them would say, yeah, the pain were not as severe in the way it was during the first day. So it's subsiding with days, and sometimes patients only take like 2 days, and then they would say, oh, I didn't feel much pain, so I stopped these medications. So that's the combination we use here.
I mean, I think that's like such a, like the approach to managing pain during UFE is, so much of it is just about managing patient expectations, right? I imagine in Tanzania, most of your patients are multiparous women who have to return home after their 24-hour hospitalization to maybe, multiple children at home and managing them. Some are little, lots of heavying. So how are you able to kind of prevent women like that who are go-getters and, managing their family from taking on too much and developing post-embolization complications?
So I would say, I don't know whether it's all the same like everywhere else, but here most people would only take medication, I would say, when they need it. Like most people are strong. Like that's one thing that we've developed. Like most people are strong in terms of pain management naturally. But so any person shouldn't have to go through like pain just because they can manage it. If you can keep them comfortable, then we tell them, see, these are the medications you can take when you feel that much pain is creeping on you, but it not necessarily that you take every day. So, but we don't, most of them, like we tell them, these are medications for pain, basically, but we just don't tell them like, oh, these are opioids and stuff. But we tell them the complications that can happen from taking too much medications. And most of them, we tell them like for opioids, mainly like constipation and stuff, but dependence, because we only give them for like 5 to 7 days.
Oh, sure. Actually, I'm like not worried about dependence at all. And like these women, I'm more worried about them like just like overdoing it and like, for my people, like going to the gym the next day or something, I guess, what kind of follow-up do you do after your procedure for these patients?
So normally we give them a call. Sometimes we give them a call like at 1 week or 2 weeks. And sometimes we would just tell them right on, like, if you don't have any issues, come back to the hospital in a month. Then we see them in a month and just check on them, like how they are, how were the first periods and all that, the pain and stuff. And then after 6 months, we see them again, and that's when we do repeat imaging. So from there onwards, if now we see like this procedure maybe needs to be repeated, we tell them. Because beforehand, then we tell them like, we're doing this procedure because of 1, 2, 3, just because of your symptoms. Because most of them, we do get referrals for like infertility issues. So we tell them we're not doing this for infertility per se, but we're doing this for symptoms. So, and then we check on their symptoms every time they come. And then we tell them if they're looking into getting pregnant, they should wait at least until that second check. When we check that everything is good, then we can tell them to go ahead with their activities.
I think you brought up a really good point, kind of like tucked in there, that a lot of our audience might not know or understand, but that UFE is safe for women who desire to maintain their fertility. And that's not a contraindication to having a uterine fibroid embolization. So thanks for sneaking that in there, Dr. Azza.
Yeah, sure. Just because we get referrals for that reason.
Yeah. Oh, for sure.
Yeah.
I can imagine. Well, for imaging, you mentioned imaging. Are most of the imaging that you get pre-procedure is just ultrasound, am I right? Or do you often move on to MRI?
No. We get MRIs then we prefer to get like a contrasted MRI pelvis, just to check like the number, to check their uptake of contrast, and then we show these women before the procedure, like, see, these are the fibroids you have, and then we can manage 1, 2, 3. And you see the color changes in your fibroids. So we do show them like a post-contrast image. And then we tell them this is not supposed to be like this. So if it's like this, that means this we can work on. But also, and then we correlate them with the symptoms. So we show them like, these are the ones that are responsible for your symptoms. And definitely in a month, you will feel better in terms of symptoms, but not the sizes, of course. Because if you don't tell them that, and then we do the procedure, and then they go back in a month, they do somewhere else like ultrasound, and then they'll tell them, oh, look, you had UFE, but still, look, your fibroids are still there. So most people don't understand that we don't really cut them off.
Yeah.
That's what we have to explain to every patient, really. Yeah.
Oh, gosh, yes, setting those expectations. That's super interesting.
Ali, that is our motto, by the way. And I'm just going to sit down. I'll turn my camera off and my mic off and just let you talk to Ali yourself, right? Because it is our motto, Ali, is that, it is the same care everywhere.
Everywhere.
Right? Everywhere. Same care everywhere. Wherever you are, whatever it is that I would do at Emory or Yale, San Diego, Sinai, where you are, Ali, is that our patients universally should accept that level of care, right? Same care everywhere. And it's funny that, as I hear, as I speak, I know that this is reflective of the teaching, the published literature, already personalized to that environment. But I just want to make sure that I put a plug in here just before I forget that, there is a real gap in what we know about how women access care in sub-Saharan Africa or other places outside of the US and Europe, because almost all the trials that Azza is quoting, telling her patients what to expect, how they should feel afterwards, the pain regimens that we prescribe are very much what I do here, that I have taught here, and then, and now passed on there. Because there's a lack of diversity within clinical trials, we don't know what it is that is happening as a population. And so I want to make a plug here for us to really do more research and understand the disease and how the disease presents and may differ, the unique challenges that Black women are facing, or women are facing in the continent, separately from maybe in the Caribbean, separately from in Brazil, as opposed to North America and Europe. And then to, encourage that studies are done to really explore that, because it is possible that what we're doing there might be different. It could be different, right? We just don't know that. So our same care everywhere is because of our inclusiveness, but it is reflective of the lack of diversity in the studies, in the people that are being studied. And so I want to ask all the folks that are thinking about clinical trials, you hear that we have the skill set We have the equipment, Lady Azza is there, and lots of others who can actually help us to understand those questions, so that this large group of people in sub-Saharan Africa that has the highest population of Black people, yet the fibroid research is so anemic in that space.
I love it. That's an amazing point. What kind of clinical infrastructure do you have to support a research program where you're at?
We've published that experience already around, implementing the UFE program in Tanzania.
In Tanzania.
So red caps exist, right? So there's a way that we can capture the data. Clearly, we don't have the same machinery of research assistants and providers around, but we do have that. And with funding, those things are capable, right? So if I were a company, what I'd be worried about is, how do I know that this is applicable to me at Emory from a technique standpoint? And I think what you're hearing is that it is still applicable. Like, we have people that are trained, we have the infrastructure of the equipment, we just don't have the consumables. But from a research standpoint, we have people who could do that, and we have red caps already in order to capture it. And if we could get companies to pay, or the people that are interested in this research to pay, we have research assistants that are trained and could do any study that is being deployed anywhere else in the world.
We didn't really touch on the cost of this to patients.
Ali, you may be able to tell us more about, in your environment, what does it really cost? Because what I tell people when they ask me that, I try to highlight the cost of not getting treatment. And it's not a financial cost. And that is so costly. However, we still have to talk about the money. It's the money. And it entirely costs too much, right? No matter what amount we say it is, it's too much. And it's too much because of what it takes to be able to do this safely in our environment in the US. Okay, so can we use ultrasound alone? No, we can't. Okay, should we use MRI with contrast? What about CT scans? And what about the imaging, afterwards? And how many particles do you need to use? And what is the cost of one particle, versus one embolics versus the other? And those are always going to be changing. And that's why I tend not to focus on the cost. But I could tell you that we know that the disease itself, fibroids itself, costs the United States $34 billion annually. It's a public health burden, right? And if we don't try to figure out how we're going to pay for that public health burden one way or the other, because we're talking about fibroid embolization here, Ali, and I know that's the cost that you're talking about, but I want to make sure that I'm talking, there's a cost to all the other things, right? Whether it is hormonal therapy, there's a cost to myomectomy, there's a cost to hysterectomy, and now we know that pharmaceutical companies are spending hundreds and hundreds and millions of dollars trying to answer some of this, because the fibroid market is actually growing worldwide. And as they're looking at that, they know that women are looking for other alternatives to surgery. And this focus on women's health, not just in the United States, but we've seen all around the world, is shifting towards these minimally invasive procedures. So we better fix and understand this financial implication sooner, because I'm speaking from the heart, but really it's the dollars that sometimes speak to others who need to make this decision. So I welcome the conversation about the cost. I just don't know it.
Well, I mean, it's like a fee-for-service model, right? So as I recall from spending time, I spent some time in Uganda in residency working with their radiology residents. And it seems like the patient has to pay for the whole procedure before the procedure happens, correct? Is that how y'all do it there too? Yeah. So how often do you get patients and it's just too much of a financial barrier for them to have the procedure?
Most of the times, I would say, especially like for all these big procedures. But yeah, the cost is less though in public settings than in private settings. So that's why some patients tend to come towards us versus the private settings, because it's more costful when they go there. But yeah, it's a barrier. Money is an issue. But then we try as much as we can to minimize the cost to patients. So usually it's just they charge for the procedure, and then whatever equipment we use, then you just add them on. So it's still an issue. Yes, it's still an issue, but yeah, we're still getting there.
But, it's just so I don't want to make this seem, Ali, that cost is a barrier. But
barrier,
if we think but it is
definitely
not the biggest barrier. Because if you think of places where cost is of no consequence, if you're a veteran, you can go to the VA and get your care. You have access because VA exists, and your care is covered. Yet women don't come to getting this care. And so I think that it is a big conversation, and we have to talk about it, but then people just run back to this cost issue and as the reason that we don't move on to the access issue, because we have to focus on the lower hanging fruit before we fix this big old fruit here.
Like, I might be wrong, but I think what you're saying is like, yeah, it's a problem, but like, that's not the biggest deal. The biggest deal is access and knowledge about the procedure, and then availability of skilled operators, right?
Right, exactly. And the geography, right? The geographic differences.
What's the farthest that somebody has traveled to see you to have a uterine fibroid embolization? Totally putting you on the spot. It's cool if you don't know, but yeah, just like an estimate.
I think she knows.
I would say like some of the patients would travel for a day or 2 days sometimes to just come and get the service. Yeah. So because we're in like the eastern part, and sometimes somebody would come from the northern part all the way to the eastern part to just get the service. So I would say, yeah.
And even in the US.
Yeah, to just go back to the same point, like the availability of services and the knowledge of services. So all those things contribute to why patients had to travel so far to get the service.
Absolutely. Well, I mean, Dr. Azza, they have a saying like, you will build it and they will come. And I feel like you're almost saturated with the you built it. Now you're just working on getting the patients to come. And it's just a really, really amazing work that you're doing there. So it's like, what is your ideal scenario, Dr. Newsome, for like, what do you want this space to be in 5 years? Like, close your eyes, tell me what your dream program is.
Oh, do you mean for Azza in Tanzania? Because the dream lives in that human being, right? Because again, one of the very important things that we have to bring in this space as we look at fibroid care globally is to try not to only see it through our lens, right? But to be able to bring the things that are needed into that environment, and then to be sure that we're adapting so that it actually suits that environment, right? So I've moved, I don't admit very many patients anymore, but like, how could I tell that you have to send patients home? Patients come from far away, right? Literally, I'm like learning all these drugs. I'm like, okay, what is that? But then I do understand that this is a narcotic combined with, acetaminophen. Oh, that's Percocet. Great. Okay. Or an opioid. Okay. Diclofenac. Oh, that's a non-steroidal anti-inflammatory. So what I really need is to decrease the swelling by whatever means. I need to be able to manage the pain control. And I need to understand that just because you're not crying doesn't mean that you're in pain. And that we understand the cultural differences, right? Which is the thing, Ali, that gets us when we are in these other spaces, understanding our cultural competency, that I can't speak in the same way that Azza understands. Like, I could give them as many Azza's like, they're not going to take this. They're only going to take it as needed. Even though I'm saying, I need you to take this, pain or no pain. Like, I say this to every woman that has a UFE here. She's like, that ain't going to happen, So it's definitely understanding that, and then actively educating our patients about what the other options are, because someone may say, well, I don't want that, but I can use that. I know that whenever I drink this certain type of tea, my bowels are loose. So then why am I prescribing a stool softener for you, right? It is, what is it that we want to accomplish within the context of that space? So I'm closing my eyes as well. And maybe I can hear this vision of Azza in 5 years. What does this ideal space look like for fibroid care where you are, right? In 5 years, what does that look like for you?
I would say in 5 years, I would really love like these patients to come in, get treated, and leave home on the same day. Because most of them, as you say, they don't really live nearby the hospital. And then they have to also ask permissions from their workplaces to come to get treated. So sometimes somebody will tell you, oh, please, can you plan me like this week because my leave only ends like tomorrow or day after tomorrow. So I would really love to have that, like for patients, like, oh yeah, we can do that. And you can go home on the same day. Doesn't necessarily mean that you'll start working right away, but you can go home and be at your own space. Because for most part, I think also recovery helps when you're around the area where you feel most comfortable with. So that's for most people, it's in their own spaces. So yeah, I mean, yeah. And then also the abundance of materials so that we can get to choose what works for this, because sometimes we have different people, different attendings. So what works for me does not necessarily mean would work for Eric, say, or would work for Mivano, or would work for Baloa. So if you have like variety of stuff and then somebody gets used to one thing, then it's a good thing if you have a variety there. So yeah, that would be my dream, actually.
And on top of that dream, I think that, these are the same dreams that I think that Ali, you're saying, that's your dream too, right? That's my dream everywhere, right? Is to also be able to think, okay, if less than 10% of women, especially women of African descent, can hear about UFE from their physicians, then we've got to increase that number. My dream would be that this symptoms related to fibroids or the diagnosis of fibroids itself doesn't become such a taboo, is no longer this taboo. That the symptoms of diarrhea is not considered a taboo, right? If you have your periods for, 10 days,
10
or
days.
Some women that have reverse periods, more times bleeding than not. If I cannot go to work for a week of the month, if everybody knows that I can't be called because my cycle is on, if I never can wear a white pair of pants ever, if I look like I'm pregnant and I'm not all the time, if I'm anemic and ice is my favorite snack, then those become these symptoms that you don't want to ever talk about them. I hope that one day someone could see that this is something that is as important to discuss with your doctor, to seek help, that your cousin can tell you, your sister could tell you, your husband could tell you that, hey, maybe you should see someone around that. So earlier recognition of the abnormal symptoms, the lack of normalization, and then to stop making menstrual cycle a very normal thing that happens, something that you can't talk about.
And actually to add, I'm sorry, I didn't mean to cut you off, but to add to that, actually that makes more sense here because of the cultural aspect of it. So most women would not talk about their periods like openly.
Exactly.
Yes, and then that also delays that seeking help. So we're let's get the word out there that it's safe to talk about, even though culturally most people would not.
Exactly. So then in that cultural sense, Ali, what we'll have to do is, if you're talking about there in Tanzania where they're going to see their doctor already, it has to be like a part of the regular intake of history, right? It's not like, are you having chest pain? Do you cough? Do you sneeze? Do you, we have that now as a part of most of our regular intake. People ask, if you have impotence, right? And it's so funny how we can ask everybody if they have erectile dysfunction, but we can't ask women if they're having,
their periods are heavy.
Exactly.
It's like a difference between men and women. Like, it's amazing how much women are willing to put up with before they'll mention it to their doctor, right?
Because we don't make it abnormal, right? So that's also a part of it. But if you asked me, and I didn't even know if it were abnormal, and I just wrote it down, then you can help me with that education. And so that education everywhere where women live may not be able to find Azza. So I think that when I close my eyes, I see the evolution of technology going into spaces where women are, where they could also learn where they live, not only when they're coming to see the doctor, right? So wherever they're gathering, maybe it's at the temple, wherever it is that, you can get this information in a culturally sensitive place, so that first, I'm not saying that all the women here are going to be eligible for fibroid embolization. I'm just talking about to understand that what is happening to my body is not normal.
It's not normal. Exactly.
Period, right?
Yeah.
And now we can talk about what are we going to do about that? Because for some, fibroid embolization will be the answer, but for some it won't. But we've got to start with this conversation about this is not so normal, and then we can personalize that care to each one of these people. That would be, my 5-year goal, and then to be able to train more people. I'm an IR. I believe in this procedure, right? But we don't have enough IRs that are trained to even do this procedure, Ali. We can train as is training 6 people now, right? Think about the places all around Tanzania alone. Forget the rest of sub-Saharan Africa or in Brazil or in the Caribbean. If we don't have training programs that are now training more people who are interested in this, then we're still going to not be able to do it, right? Because I don't know about you, but, cancer care and IO is like what everybody thinks IR is, And then it is and then this women's health over there, and everybody can do that. That's like doing a VAS cath, right? Which is ridiculous. So if we don't, again, have some strategy to increase the number of IRs who are trained in performing UFE safely, not just, can I get a catheter in there and what do I need to do? Understanding how to talk to women, understanding this post-procedure care, then our healthcare to women will be limited. And that's training more women in IR. Let me just flat out say it, right? It is, we need to train more women in IR, and then we need to train more men who
can do this,
are for women, right? The he for she's, right? Who understand that and could stand on the podium and help us with this narrative, right? The people that are our leaders who can talk about this, because 20 years of UFE, and yet we're still at the same penetration. We've got to do more about that.
Do you feel like out of the road to IR, the interest from U.S. trainees and road to IR, do you feel like it's substantially more female trainees who are interested in it, proportional to how many women are in IR, or you think it's like 50-50?
I think it's like 50-50, right? We've been lucky enough to have like a woman in every class until this current class, which is all men now. But every class that's been there, it had almost like 1-to-1 or 1-to-2 maybe, women to man ratio. So it's been 50-50, I would say. And we don't really, we by design. And we just like, we tell everybody like, you can join this. We do encourage women to join, but it's not always that you'll get most people.
You're talking about the Tanzanian trainees. I am curious about the folks you bring from the U.S. Yes, because I suspect that, IR is only 13% women. IR trainees, 13% women.
Yeah.
But do you feel like you have more equal representation between women and men of trainees you bring over?
I would say fairly we do have, like, it's 50-50 because we've had amazing women come through and then men. So it's almost the same number, I would say.
Yeah.
I think because she's counting some people twice.
Maybe.
Maybe. I don't know that we've ever looked at the numbers, but you're right, as
No,
it feels that way. It feels that way, but I know that it can't be that way, right? Because it can't be that we're taking the 13% and sending 50% of them relatively to the other percentage. And because this is not just people that are interested and volunteer their time to that program in the US, like we have people that have visited from Canada and Germany and Europe, etc. And if you think about that visiting crew, they're still mostly men.
Yeah.
Right. So it's not that. I don't think that we can say that the thing that moves people to want to come to places like Tanzania or Rwanda, Uganda, Kenya, Nigeria, to try to help with instituting a training program. And I'm not talking about medical missions, because people from anywhere, walks of life, will be able to do that. I think it's something that transcends that gender. What Azza was also getting to is that we have to be more deliberate about recruiting and retaining women that are interested in procedural medicine all around the world, but especially in places where this has been a taboo, where their medical communities have not grown up enough. It is not that women cannot be doctors, right? Which is where you see that is quoted in the UN, or when people talk about our equal representation of women to men as physicians, is that women are typically shied away from the procedural spaces for lots of reasons, right? So it will take a longer conversation to talk about how do we increase more women in procedural spaces, but we know that we're doing it by just showing up and having people like Azza stand up and say, yes, this can be done, and it can happen even if you're married and have children, says Latifa. It happens if you have a big family, and if your husband is also a professional in medicine, says Morvano, right? And you can actually have a baby while you're in training. Those other things that are these barriers that have been put up. And Fonzing would testify and say that if this is what you want to do, you can go to another country, learn that language, and still be able to do that. And then, yes, I want to be able to help other women in my community. And so these people, they help to rejuvenate my own energy. And whenever I feel that I could be a little bit weak or losing my hope about how we can work here, and where uterine artery embolization is more established for fibroids, I'm already rejuvenated by the creative ways in which places in Nigeria and Ghana and Brazil, the Caribbean, and yes, in Tanzania and in Uganda, that they're saying, no, you can't lose hope, because hope lives here, right? And it is in this space that we're going to be able to answer some of the other questions that you don't exactly know. And these are questions about quality of life, right? These are questions, none of those women, they love these pretty pictures, and I show them to everyone, the before and afters, but they don't walk around understanding that their fibroids are getting devascularized or any of that stuff. They feel this overall impact in the quality of their life, and that now I can show up more as myself in my community. Now I could be that mother because I have this energy, and I could even think about having a baby because I'm interested in sex. And I think that those are that framework, Ali, is what talking to Azza helps me to develop, and Morvana helps me to develop, because we always try to think that we need to come up with these scientific parameters, right? But the real impact to patients is what they're seeing every day and studying every day and able to market every day, not the percentage of shrinkage or what particles you're using and none of those foolishness, right? They're showing us that if we meet women where they are, if we provide access, and if we're creative enough, that we can make an impact anywhere we want to.
Amazing closing words there. Love it. So you kind of summarized everything for me. Dr. Azza, can you give some closing remarks to our audience? What do you want from us to help you succeed?
As she had put it, the best thing we can do, for treatment of these fibroids, even here, is probably to get the word out there, to just spread the word to all the women of all the colors, of everywhere, of all the cultures, that it is okay to seek treatment in these, what is normal and what is not normal. To know, first of all, to just know that this is not normal and to seek medical advice. And then the other thing would be to be able now to give these treatments to these women of all the places. So it's not only for the women that can afford it, it can be for anyone. Anyone that is suffering from these should seek medical advice and should be able to be treated. Everybody has their right to choose which treatment modality they would take, and it shouldn't just be as a last resort. That's what I can say.
It's super cool to hear how the program has evolved over the past 5 years, and just I'm super excited for the next 5 years, and to close my eyes and see that dream that you just talked about come true.
Amen to that.
And then to emphasize that this program is like not just in Tanzania now. We have a full-fledged program in Uganda. We are training people already from other places in the area that are going back, and to start our program in Rwanda in earnest, hopefully in the next couple of months, and then to plant these programs everywhere, right? And again, the training programs provide the basis for where our soldiers will go to bring the information so that women will have access. The overall access issue is one for everyone, right? It's for everyone who has a voice and who has a mouth, who can, when they're talking to women about their breasts, to also ask about their periods. Whenever they're talking to their sisters about something else, to ask about that, because, everyone that is alive today is born of a woman, at least so far. And, we are still, all of our sisters are keepers. And to be able to say, how are things going? And like, for real, are you having troubles with your periods or with your cycle? Because this is such a prevalent disease. I think that is the beginning of the access, and really complex issue, but I'm so glad we're talking about it. And I want to thank Backtable and the sponsors for giving us this platform, because we know this reach a lot of people, right? To hear about, what's happening with access to fibroid care, not just where we are here in the US, but globally, and to hear more extensively from sweet Azza, who works day and night and day with the team there at Muhimbili National Hospital, not just to train people in doing this procedure, but performing a lot of the work on women's health there. So I applaud you, Sweet Azza and Mirvana and Below and Eric, for all the work that you have to do in lifting this procedure to help many, many women there, that we have been doing here in the US and elsewhere in the global north. And just know that you're never alone and not alone, and Backtable is here, and we're all here to make sure that we're helping you to answer these questions around access to fibroid care. So thank you, Backtable.
Thank you so much.
Varian.
Oh, y'all, I'm getting the feels. Oh my gosh, getting the feels, Love it. Well, yeah. Dr. Newsome, Dr. Azza, thanks so much for being on the show.
Thank you so much for having us.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_Backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and Digital Marketing led by Brian Schmitz.
Social Media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.